This session is called What's Next? Upcoming and Ongoing Clinical Trials. And the idea is that we would like to keep you awake after the lunch break. And Professor Lewis calls this the clinical trial parade. So what we will do is show you slide after slide, trial after trial in a rapid fire. So lots of information, but there is no time for question and answer. So this is not meant to be that we discuss the trials. It's more that you see what's cooking. So you can lean back and just listen. Don't fall asleep. And there's more coming, of course, today. So there's a lot more for you. Okay, so I will start this round, and this is about ACS and antithrombotics. So let me start with this. So this trial is not ongoing anymore, as you know. It was published this summer. It's the COMPASS trial. And the COMPASS trial was asking the question whether anti-10A is better than aspirin in the chronic atherosclerotic setting. So in patients with CAD or PAD, many patients, 27,000 patients. By the way, I realized that all these big trials have 27,000 patients. Did you realize that? I don't know why. Is that power calculation, sample size? I don't know. Anyway, so 27,000 patients, chronic CAD, PAD, no atrial fibrillation, very important to say. So in this trial, it was tested whether low dose, very low dose rivaroxaban treatment together with aspirin or low dose rivaroxaban treatment was better than aspirin treatment in the chronic situation. Follow-up 24 months, and this trial was stopped because of superiority in one of the treatment arms. So this is what we saw. These are the Kaplan-Meier curves showing for the aspirin group, and this is the rivaroxaban without aspirin group, and you can see there is some difference, not statistically significant, so just anticoagulation is not enough, so we can forget about this. Now then we have the combined arm, rivaroxaban 2.5 BID, so very low dose, together with aspirin, superior compared to aspirin alone. So we can see this here. Here's the p-value of this over a period of 24 months of treatment. So this was a combined endpoint that was investigated here. It's a MACE endpoint, classic MACE endpoint, cardiovascular death, stroke, MI. And you can see here a statistically significant benefit, relative risk reduction, 24%. So when you look at the individual endpoints, interestingly, cardiovascular death was less frequent, stroke was less frequent, but not MI. So this is different from for example, Pegasus, where a prolonged dual antiplatelet therapy was investigated in this session. So on the other hand, and that holds true for every single trial that I know that compares more intensive, at least antiplatelet treatment or anticoagulation treatment, in all of these trials we see we have more intense treatments, we have less ischemic events, but always at the expense of more bleeding. So here you can see this, more major bleeding events, hazard ratio 1.7. So this is true as well. Not more intracranial hemorrhages, not more fatal bleedings, if you look at this. Okay, so what else do we have? There were combined endpoints, which combined the MACE endpoint with lower extremity endpoints, very significantly lower. Then there's mortality. And this is now interesting. You see a p-value of 0.01, and people go and say, oh, mortality, total mortality was reduced. This is not true. There was a statistical assumption. It's written down here. This was pre-specified, so only if this p-value was achieved, there was a significant difference in mortality. So we have to take from this trial that total mortality was not significantly different. Very interesting was this. They did an analysis in PAD patients, and you can see this. This is major adverse limb events, which is all kinds of revascularization procedures, amputation, stuff like this. A very dramatic endpoint reduction, relative risk reduction, about 50%. And this is major amputation. So we're not talking about a toe. It's like big chunks of legs, for example. And you can see here, it's a 70% relative risk reduction, highly statistically significant. So quite interesting. But again, also in this group, bleedings were more frequent. So 1.6 was hazard ratio. So now we have a very interesting trial supporting the atherothrombosis concept, but I think it raises more questions than it's giving us answers, because we don't really know what do we do now. Now we have another concept. So this is not dual platelet, antiplatelet therapy. This is now anticoagulation with antiplatelets. I think it's quite interesting to see that strokes were less. Why is this? So I think lots of work needs to be done to really understand what this trial means. It is a very important trial, but we don't really know what it means and which patient will benefit. Okay, what's next? So there was a trial called Gemini ACS, which tested the hypothesis if we can replace aspirin by very low dose, again, rivaroxaban treatment together with another platelet inhibitor for patients with ACS. 3,000 patients. All of them had an acute coronary syndrome. They received clopidogrel or ticagrelor, so P2Y12 inhibitor, and then they were randomized to receive rivaroxaban 2.5 BID or aspirin. So dual antiplatelet therapy or one platelet inhibitor with low-dose rivaroxaban. This was powered for bleeding events, and there was no significant difference. It looks like a trend, but it's not significant. This is bleeding. And this is ischemic endpoints, so same trend, but this was not significant. So the company decided to go on and to test this principle. The idea is to reduce bleeding, to test this in a bigger cohort. It's called Gemini ACS2. This is an outcome trial testing this concept in more than 20,000 patients. So we will see what will come up there. Okay. Now, this is a trial just published. It was shown at the ESC meeting. It's a trial originating from Munich. It's called the Tropical ACS. And the question of this trial was, can we de-escalate platelet therapy from a very potent platelet inhibitor like prasugrel to less potent clopidogrel in order to have less bleeding events? This is the question behind this trial. And I have to explain what they did. So 2,600 patients with acute coronary syndrome undergoing PCI. So all of them were stented. STEMI cohort 55%, majority had drug-eluting stents, and about the half had radial approach. So these patients were randomized to a classic, they call it control group. So these patients received aspirin plus plus prasugrel, and the other half was randomized to receive 7 days of prasugrel. Then they were switched to clopidogrel for 7 days. And then it was meant to find out whether or not there's good platelet inhibition or not. So they did a platelet function test with the multiplate to find out the non or the low responders to clopidogrel, because those were meant to undergo more intensive platelet inhibition with prasugrel. So one half of the patient received clopidogrel, then they did the platelet inhibition test. Low responders continued with prasugrel, and good responders continued with clopidogrel. So this was the trial. And what they saw was this. There was 40% low responders with clopidogrel, so those patients continued with prasugrel. Okay, very interesting concept. What is the findings? So this is the combined net benefit endpoint. You see less events in the de-escalation group. This did not meet superiority, it met non-inferiority. The same holds true for the MACE endpoint. Keep in mind this was powered for bleeding, not for ischemic events. But when you look at the bleedings, there were less bleedings, but this was not statistically significant. So the trial was there, it was designed to produce less bleedings, and that didn't work out. But non-inferiority. So the question is now, what do we do with this one? This is another concept. So we have the concept in high bleeding risk patients that we reduce the time of dual antiplatelet therapy after ACS. So this is yet another idea. So what should we do? For me, it's quite clear. We have 2,500 patients here. We have 30,000 patients in the trials like Plato and Triton that set the stage for the guideline recommendations that we have. This concept requires platelet function testing, which is not even recommended by the guidelines. So for me, it's quite clear. Interesting trial, but we should stick with the guidelines and do dual antiplatelet therapy with aspirin and either ticagrelor or prasugrel. Okay, the next is a ticagrelor trial. It's called the Global Leaders Trial. So what they do here is patients, all-comers design, ACS and stable CAD, quite a big cohort, 16,000 patients. And here's the experimental strategy. Patients will receive aspirin for just 1 month and ticagrelor for 24 months. Okay, completely different from what we've done before. And the reference treatment is all of them receive aspirin. And if they come with ACS, they will receive ticagrelor for 12 months, which is standard. If they come with stable CAD, they will receive clopidogrel for 12 months in this case, which is not quite standard, but anyway, so this is what is done. So we compare aspirin for just 1 month and then a longer period of a more potent platelet inhibitor, and this will be compared to kind of standard treatment that we have right now. Very interesting concept. This trial is recruiting, as I know, so we don't know what will be coming out of it, but interesting concept. Okay, so the next part is triple therapy. So patients with atrial fibrillation that have a heart attack or receive a stent. So we need classic treatment is dual antiplatelet therapy plus oral anticoagulation. So there are 4 trials running or now completed that test triple therapy versus dual therapy, NOAC versus warfarin. So I will show you this. ReDual and Pioneer AF have been published. Augustus and Trust are ongoing. Okay, now I cannot move forward. Could you click to the next slide, please? I can't move on. Could you please click to the next slide? Thank you so much. So this is now the design of the Pioneer trial. I think I shouldn't say that. It's a typical design of this group. It's a very complex design by the TIMI group. So what they did was the following: 2,000 patients with atrial fibrillation requiring anticoagulation. Patients, all of them underwent stenting. Half of them were ACS patients. 4% received ticagrelor, the rest of them clopidogrel. And I have to state that high-risk bleeding patients and stroke patients were excluded. So what they did was the following. They had one arm with rivaroxaban 15 milligrams, so reduced dose for stroke, together with the majority clopidogrel, which is like the WOOST trial design. There was one arm with triple therapy receiving 2.5 rivaroxaban BID plus aspirin plus clopidogrel. This is like the ATLAS trial. And there was one arm triple therapy with warfarin, aspirin, and clopidogrel. So then there were different strata to go for 1 month, for 1 month triple therapy, 6 months, 12 months, very complicated design. The majority, I have to say, received triple therapy for longer than 6 months. So this is important when you interpret this. Then the trial went on for approximately 1 year. So the comparison is dual therapy with rivaroxaban in a slightly reduced dose with clopidogrel versus triple therapy with rivaroxaban 2.5 BID, very low dose, or classic triple therapy with vitamin K antagonists. Okay? So, and this is the result. The endpoint was clinically significant bleeding, which is major bleedings, minor bleedings, and bleedings requiring medical attention. This is the definition. And you can see that both rivaroxaban groups had a lower incidence of bleedings compared with triple therapy. Major bleedings were reduced but not statistically significant. So this is what comes out on the bleeding side. The trial was powered for bleeding. This is the ischemic side. So this is the MACE endpoint CV death, MI stroke, and there was no statistically significant difference between the groups, very wide confidence intervals. But at least there was no clear sign of harm. When you look in the details in one strata, which was 6 months, the rivaroxaban group, which is group 2, 2.5 milligrams, there were more strokes and a tendency towards more stent thrombosis. Statistically very difficult, but as you may know, the 2.5 dose was not approved by the regulatory bodies in this setting of triple therapy or post-stent. So we don't have that anyway. So it's the 15 milligrams dose that we have. But this is the ischemic side. So this trial, as the other one that I will show, was powered for bleeding. It was not powered for ischemic events. That's important to say. You'd need 20, 30, 40,000 patients to have an adequately powered trial to see differences in, for example, stent thrombosis. So this is true for Pioneer, but also for this trial. And again, I can't go on. Could you click to the next? There you go. Thank you. Which is the ReDual trial. ReDual was published again this summer. It's testing dabigatran in this setting. So again, patients with atrial fibrillation and stenting, 2,700, 50% ACS again. The majority had DES, and quite a large number had ticagrelor, 12%. So here the test was dabigatran 150 BID plus clopidogrel, which is the standard dose, the higher standard dose for stroke prevention in AFib patients. Then there was dabigatran 110, which is the lower approved dose with one platelet inhibitor. And this was compared with triple therapy with warfarin, aspirin, and clopidogrel. But here there was a very clear definition. In case of a bare metal stent, just 1 month of aspirin, and after 3 months, aspirin was discontinued for drug-eluting stent, so a shorter period. So this is not just investigating leaving away aspirin, but it's also really comparing NOAC versus warfarin therapy. So here we have dabigatran 150 BID. In a dual therapy arm, we have dabigatran 110 BID dual therapy and classic triple therapy with vitamin K antagonist. Okay, here we go. So these are the results. This is again a combined bleeding endpoint, which is the ISTH, not the TIMI definition, but major or clinically relevant non-major bleedings. And you can see here relative risk reduction 50%, absolute risk reduction 11% for the 110 dabigatran arm. And if we look at the 150 arm, and that was quite surprising to me that we have the high dose of dabigatran, but also in this there was a 30% relative risk reduction and 5% absolute risk reduction in this bleeding endpoint. When you look at absolute risk reduction for major bleedings, you can see this, even for major bleedings, and this is different from the other trial. There was 4% less bleedings in the 110 arm and almost 3% less major bleedings in the 150 arm. So I think quite a pronounced effect on bleeding. And again, checking for ischemic endpoints, there was no difference, but the same notes of caution are here because this trial was powered for bleeding and it was not powered for ischemic events, but at least there was no signal. When you look into the details, you can see that in the dabigatran 110 arm, there was slightly more stent thrombosis, very low numbers, but again, this is raising the question if this is safe in terms of ischemia. We don't know. So, what else is coming up? So apixaban is tested in a trial called Augustus. So in the Augustus trial, it's the biggest, 4,600 patients are planned. This will randomize patients to vitamin K antagonist or apixaban 5 milligrams BID, so the standard dose of apixaban treatment. And then in a 2x2 factorial design, patients will receive aspirin or placebo. So this is testing NOAC versus vitamin K antagonist in standard dose, and also testing aspirin or not aspirin, so it's testing triple therapy versus dual therapy. Very interesting. We will have to wait. Recruitment is like this. Almost 2,900 patients, well, 2,900 were recruited in November, so this might be done at the end of next year. We have to see. So we have to wait for this. And last but not least, here's something else. Another investigator-initiated trial with apixaban. It's called the Approach ACS, coming from Munich. This will test dual therapy, apixaban twice daily plus clopidogrel. And this will be compared with triple therapy with warfarin, aspirin, clopidogrel. And here is a difference in patients with low bleeding risk. Triple therapy will be for 6 months. In patients with high bleeding risk, this will be for 1 month. So this is kind of following the actual ESC guidelines. So, but this trial is recruiting, and we will have to wait as well. There will be one trial with edoxaban called the Entrust trial, which will randomize the same patient cohort. 1,500 are planned to receive edoxaban 60 milligrams with one platelet inhibitor or classic triple therapy with vitamin K antagonist, aspirin, and one P2Y12 inhibitor. This is recruiting, and we will have to wait. Okay, now different topic. Very briefly about antidotes and reversal agents for NOACs. This beautiful position paper was published by our working group and the working group of thrombosis. Alexander Niesner was the first author. And this is summarizing what we have as principles to check for NOAC reversal. We have one small drug, a small compound that is called seroperentak, which is meant to inhibit all different NOACs. There's an antibody, idarucizumab, which inhibits dabigatran specifically, and there's one compound, andexanet alpha, which is a truncated factor 10, which inhibits the 10A inhibitors like rivaroxaban, edoxaban, and apixaban. And to make this short, the clinical trial program is different. So what I would like to show, seroperentak, the universal magic bullet, has just entered phase 2, so it's very early in the clinical trial setting. Phase 2 is enrolling. Idarucizumab, reverse AD, the full study cohort is published, and this drug is available in Europe, as you may know, this Praxbind. And andexanet alpha, it's the ANNEXA trial. Interim results were shown, and approval is pending. There are several issues that need to be solved, so we still have to wait for this drug. Okay, my last thing is this, very interesting concept. It's about a factor 11 inhibitor. So what is the rationale? Factor 11 is implicated in clot formation, but not in hemostasis. So the idea is if we inhibit this, we will have less thrombosis, but not as much bleeding. This is the rationale behind this. And this has been investigated with an antisense oligonucleotide. And in VTE patients, this worked. So the nucleotide produced less VTE events and less bleeding. So this was a small first trial. And now there's an antibody that is developed, and this antibody will be tested in a clinical trial called the Foxtrot study, where different dosages will be compared with enoxaparin and apixaban. So this is something very new and upcoming, very interesting principle. And I will finish this with this. This is also important. I think it's CAD, it's ACS. I don't know if you know this very important study from Finland, okay, from Mr. Kivimäki, published in The Lancet. This is investigating the working hours per week and the risk of coronary artery disease and stroke. And you know, cardiologists think we all die from heart attack because we have to work so much. And I can show you here it's not true. The risk of heart attack is not higher. But look at this, check it out. If you work more than 55 hours a week, you have a higher risk of stroke. So you got to be careful. There you go. So now we may have an explanation for this. Look at this. If you work more than 55 hours, you have a higher risk of atrial fibrillation. So there you go. But be careful. This is just an association. It's not a causal relationship, okay? In terms of science is just an association. And I have something else that you have to keep in mind, and then I'm done, Basel, and then it's your turn, which is very interesting, working hours and risk of divorce. To tell you, the ladies in the room, there's no association whatsoever for the ladies, but for the men in this room, which is very interesting. There's a dose dependency showing the longer the working hours of the men, the lower the risk of divorce. Okay? Yes. So now you have to think about what you want. You want stroke or being divorced? Think about this, and with this, I'm done. Thank you very much. There are no questions allowed, and Basel Lewis will continue with his talk. Thank you.